Okay, I'm going to ask you to put up your phones, please. And no charting and no texting.
Ringer's off.
Okay, ringer's off. It's showtime. Okay. As you know, state has come in and given you a deficiency on skincare and wounds. And so part of the requirements to clear that tag is to have someone come in and give you a presentation or a talk to help you clear that tag. My name's Bonnie Flemister. Okay, I'm a geriatric nurse practitioner. I've worked in nursing homes for 20-some years. Okay, but I'm also a wound ostomy continence nurse, and I happen to live in the Kilgore, but have worked in Tyler and Longview, and have been here before. But what you need to know is that I really am known on the national level. Okay, and I just stuck this up here so you would see something. This is the national guidelines that's covered by Medicare and just nationally, and you will see that I was one of the authors, okay? So even though I'm from around here, that I still need you to know that we've got really good nurses in the area, and you're some of them. What I want to know is, who are the assistants here? Who are the nursing assistants? Okay. And then the rest of you are nurses? Do we have therapy or anybody else in here? Okay. So, the first thing I want you to think about is that all wounds are not pressure injury. Okay. When I first started doing wound care in the 1980s, everything was a decubitus. Didn't seem to matter what it was, but it was, you know, the doctor saw it was an opening in the skin, and therefore it was a decubitus. But you need to know that's not true. The most important thing, if you don't learn anything else from me today, this is the most important thing. What is the cause of the wound? Okay. Because you cannot possibly fix it if you don't know what caused it. It's just like if you went to the doctor with a cough, unless that doctor knows whether it's pneumonia, cancer, tuberculosis, okay, a cold, a virus, they're not going to be able to treat it unless they know what the cause is. So anytime that there's a break in the skin, you have to find out why the break is there, what's causing it. The first thing we're going to kind of cover is that this is just a graphic of the skin, and the epidermis is this top layer, and the dermis is the second layer, and the third layer is the subcutaneous or the fat layer. This is important for you to know, okay? This is just a small, small portion of the skin. The reason why it's important is because how deep the wound is will tell you how it's going to heal and what you need to do to fix it. So there are top-bottom wounds and there are bottom-up wounds. And usually top-down wounds, things are caused from the injury on the surface of the skin, are top-down. And then injuries that occur below the skin level, down at the bone level or muscle layer, are bottom-up injuries. And this is pretty new information. This has just been in the last maybe five years. So the physiology of wound healing is no matter what caused the wound, no matter what the severity is, it's only going to heal in one or two ways. Regeneration, which means repairing itself, or replacement. The cells that are damaged are replaced with a different kind of cell. So partial thickness wounds, and that this is partial thickness wounds, are the wounds that are the top surface. What you see, the epidermis, and the layer right below that is the dermis. And what I want you to think about is the dermis is what you see when you see a broken sunburn blister. Okay, it's no deeper than that. So anytime you see a partial thickness wound, then what you're looking at is the dermis. the same as a broken blister. So wounds that are confined to the epidermis and dermis replace or regenerate themselves. They have a cell that splits and makes two cells, and that's the way the wound heals. So the epidermis and the dermis regenerate. They have one cell that splits and makes two cells. There's no granulation tissue, and we'll talk about that, and healing occurs with no scar. So if you have a sunburn blister and it breaks and it heals, it doesn't leave a scar. So wounds confined to the epidermis and the dermis regenerate. Now partial thickness wounds are generally top-down wounds. They're going to be caused by incontinence, irritation on the surface of the skin, skin tears, where you tear the epidermis off of the dermis, friction, and stage 2s. So what I want to point out to you that if it looks like a broken blister, it's a partial thickness wound. Now healing by replacement, that's after the dermis. Anything below the dermis, which is the fat layer, the hypodermis, muscle and bone, all heal, or anything below the dermis repair by replacement and scar tissue. And this is what it looks like. You have a wound, then it starts replacing with granulation tissue, which is not skin. Okay. It's another different kinds of cells, and it's got a lot of blood supply in it. And that granulation tissue begins to fill up the defect in the wound, and then it's covered with scar tissue that sometimes gets covered with epidermis. So the skin can't, in a full thickness wound, you can't pull the skin edges together. There's a layer of granulation tissue that gradually fills up the defect in the wound by replacement, and then wound contraction pulls the wound edges together. And wound contraction is pretty much like you've seen a wound and then it pulls together. That's what happens when you get your ears pierced. And the change is complete with scar formation. What you need to know is that scar is never as strong as the original skin. So full thickness wounds that you've generally seen are venous ulcers, arterial ulcers from poor blood flow, diabetic ulcers, and then pressure injury. Okay. And pressure injury is because fascia, which is that fat layer, and muscle have a lot of blood supply, and they're more, because they need so much blood, they're more prone to, if the blood supply is cut off, to break down. Okay. So what I'm telling you is that in full thickness wounds, they're harder to heal because they have to be replaced with a different tissue. So the goals are, if you're going to try to help a wound to heal, that if it's a partial thickness wound, all you need to do is to help those cells regenerate. Okay, so what you need to do is keep the wound bed moist and protected. A full thickness wound, you need to find a dressing that's going to help control the bacteria and germs or fungus that are in the atmosphere. Okay, and then you also have to control the drainage and to provide an environment for that full thickness wound granulation tissue to occur. Dressings and treatments, well, you just have to follow your protocols and set up your good protocols, and those should be based on good clinical backgrounds. Okay, and then you choose a dressing based on wound assessment, what you're seeing with your eyes, what your treatment goals are, okay? And then whatever the manufacturer recommends. Never use a product that's not recommended exactly how the manufacturer says to do it. The 4 Ds for dressing: if it's dirty, clean it. If there's a bunch of debris in it, you debride it. If there's drainage, if it's dry, you moisten it. If it's moist, you maintain that moisture. If it's wet, then you absorb it. And if it's deep, then you fill it up. You never have an empty cavity there. That wound bed always has to be full of some dressing. So in a pressure injury, what are you ignoring? Well, you have to set your goals. Do not set goals that you can't possibly obtain. I cannot tell you the times that I've seen nursing care plans that says this wound is going to heal in 3 weeks. Okay, and there's no way. It's a full thickness wound. The patient has all kinds of other stuff going on. Set realistic goals. Determine what's causing it. Please, number 1. Number 2, does the resident have the ability to heal? It's possible they may not. And so don't set a goal that a wound's going to heal if there's no way. If a resident has an arterial ulcer, there's no blood supply to the foot's turning black, the toes are dropping off, there is no way that's going to heal. Is the patient committed to the plan? Y'all, I'm a nurse. I do stuff with you. We know very well that there are residents and patients out there that no matter what kind of a goal we set, for instance, if you have a diabetic, okay, and they have a diet to follow and they're going to go out and get that Coke and candy bar every single day, okay? So you have to make allowances and be sure to document, and nursing assistants, you need to tell the nurses when you have a resident who's not following the plan of care. You see more, listen, I told you I worked in nursing homes. I know who has the day-to-day, almost minute-to-minute contact with that resident. It's the nursing assistants and aides in this room who know what's going on with the resident more than any nurse in this room. Because the only way we nurses find out what's going on is if you tell us or you ask us to look or you give us information. And then the wound status, what's the resident's quality of life? If you have a hospice patient who's just miserable and in pain, and you have orders to turn them every hour or every 2 hours and they're screaming and crying every time you turn them, then you need to change the plan of care. So what will the response and chance of the patient overcoming the cause? Okay, we figured out what the cause is. How do we get rid of the cause or reduce the cause? Okay, the National Pressure Ulcer Advisory Panel, the beginning of this last year, changed a whole bunch of stuff in the national guidelines, okay? So the first thing is we don't say pressure ulcer anymore. We say pressure injury, okay? And the reason is because you have other kind of injuries, and the thing is you say ulcer, and that's a red flag to every attorney and everybody in the state to say this is a bad nursing home. Okay. The other thing is you can have medical devices can be the cause of pressure. Somebody lays on a Foley catheter. Okay. They removed the term suspected from deep tissue injury. Now they're deep tissue injuries. We no longer say stage 1. Oh, I'm sorry. We no longer say stage 1 with a Roman numeral 1 and stage 2 with a Roman numeral 2. They're 1, 2, and 3. So, what's the cause of the injury? Well, here's what happens. You have bone, and between that bone and the bed surface is tissue, okay? And if you put enough pressure on that skin that the bone, here's, watch. If I press, there's bone right here. If I press that hard on that tissue up against the bone, the blood can't flow through there. Okay. What happens if you have tissue that no blood goes through it? It dies. Okay. So that's what causes a pressure injury. You're compressing the tissue between the bone and a hard surface, and the blood can't get through it. You need to know that friction is not pressure. So when do you assess? Well, long-term care, you need to do an initial assessment as soon as the resident is admitted, okay? Hit the door, skin. You need to reassess weekly for the first 4 weeks, okay? And then monthly to quarterly after that if they're up and walking around and not getting sick in between times. And then long-term care, the resident usually develops a pressure injury within the first 4 weeks of admission. You hear me? So that's when you have to pay the most attention, is the first month that they're here. So what's the source of the risk? Well, this is a Braden scale, and we nurses live with this forever. Okay, and it has most of the risk factors on it. Most of them are just common sense, and I'm not going to go over them. The other thing you need to do is you need to pay attention to what the residents' other diseases are. If they have heart problems, the blood's not flowing through their body like normal heart flow. If they have diabetes, that's another problem. Are they on steroids? Because steroids cut down on healing. Do they have other problems with blood flow? Does the resident refuse some of the aspects of care and treatment? Okay, and we know they do that. What you need to do is report it if you're an aide, and if you're a nurse, document it. Are they cognitively impaired? Is their skin exposed to urine and stool? Do they have malnutrition? Which, by the way, I don't know whether you know that over 60% of the elderly, healthy elderly admitted to the hospital are malnourished. So if they're malnourished going into the hospital, they're certainly going to be malnourished coming here. The pressure, if they have had a previous pressure injury, if they've had a pressure injury before, remember I told you that scar tissue is only about 80% as strong as regular tissue. So if they've had a previous ulcer, you need to watch that area because it will break down again more easily. And then recurrent breakdown. 3s and 4s are going to watch. So what you need to do is you need to eliminate or reduce the risk factors, all that you can in the care plan, nurses, okay? And what you can't fix, you need to document in the documentation and why you can't fix it. So which of the risks can nurses really do anything about? Can we really do anything about their physical condition? Not really. Can we do anything about their activity? A little bit. We can make sure that they're active. We can get a PT referral. We can make sure they move around. Immobility, if they're ordered to be immobile, there's not much we can do about it. Can we do anything about their mental condition? No, we really can't. Can we do anything about continence? Well, we can keep them clean and dry, but we really can't fix the incontinence, okay? And what can we do about their poor nutrition? Okay, I want you to know that it takes anywhere from 2,700 to 3,500 calories to help heal a stage 4 pressure injury. Okay. So, 3,200 calories is a T-bone steak, a baked potato with everything on it, a salad with blue cheese dressing, 2 slices of Italian bread, a piece of apple pie with ice cream. Now get that in your 80-year-old. Okay? So pressure injury prevention, you need to do a daily skin assessment and prompt intervention for any evidence that you've got even threatened breakdown. And I know, like I said, I know who looks at those bodies every single day. So this is the responsibility of the nursing assistants. Okay, pressure relief, the way you relieve the pressure is you turn, you reposition, and you get support surfaces. And then you maximize the nutrition as much as you can. If you're worried about a resident not eating, if you have somebody who hasn't eaten well for 2 days, they're already probably malnourished. Now they're at even greater risk. Okay. Be generous with your nutritional assessments. Be generous with getting the dietitian in. So what do aides do? This is what CMS, this is what Medicare says, that you should do a head-to-toe assessment on admission and at least daily. Any changes should be documented in a description of the skin changes as well as anything you've done to try and fix it. Okay? They say that nurses, assistants, CNS, the parameters are every day you need to pay attention to the skin temperature. You need to pay attention to the skin color. Are they more pale? Are they flushed? Their skin turgor, you know what that is. Skin integrity, is there any breaks in the skin? And what's the moisture status? Is their skin dry? Are they sweating? Okay. And diaphoretic. Those are the 5 things that you really need to assess every single day and make sure that the nurse that you report to knows that you looked at those things. Repositioning, they're really important and critical for anybody who depends on you to move them. You have to pay attention to how mobile they are, what their level of activity is, what their general medical condition is. Okay, the more frail and fragile they are, the more you have to pay attention. What is their overall treatment objectives? What's their skin condition? And if the skin condition and general comfort should be assessed regularly. How you reposition and when you reposition should be monitored and reviewed. Okay, this is called the 30-degree lateral position. Okay, what you do is you have the resident laying on their side, but not directly on the greater trochanter, off the sacrum, okay, with a pillow between the knees. You've still got that ankle bone on the outside that they're laying on to watch, okay. And I think this is wonderful, and it's all the books. In all the books, I just never could get anybody to stay there. Pressure reduction. You need to elevate the heels. Wouldn't it be nice if we could just put them in high heels, but that's not going to work. We need to put support beneath their calf and try to support their knee, okay? Because if you hyperextend that knee, you can cause injury. You remove bedpans promptly. This was a resident that I had when I first started as a wound nurse at the hospital, and they put this lady on a bedpan and left her on it all night because she had diarrhea. Okay? We didn't know about deep tissue injury then, but that's obviously what that was. She went back to the nursing home and was back in 2 weeks and died from that. You need to be sure that if you have someone with a wound that you position them off of it. You need to help get an appropriate skin surface. So what is pressure redistribution? Well, the purpose of redistribution, the purpose of putting a specialty mattress on the resident's bed is to get them to float in the mattress. It's just like, imagine you're sitting in a bathtub, okay, and there's no water in it, and how hard it is on your bottom and your heels and your elbows and everything that's touching the bathtub. Then you put the plug in the tub and you turn the water on, and as you begin to float, you begin to reduce and relieve the pressure on all those areas. So that's what you're wanting to do. You're wanting your resident to float in the mattress. And this is just a picture of if they're laying on a regular mattress, you know, how all that pressure is on the coccyx. But if they're in a pressure redistribution mattress, then they're floating in it and you're redistributing the pressure. Now, here's one of the deals. I would bet my next month's income that you do not have a regular hospital mattress in this facility. No. Okay. I bet most of you don't even know what a regular mattress is. A long time ago in a galaxy far away, we had these, every hospital and every nursing home had a mattress that was about 8 to 10 inches, and it was covered with a hard plastic that you could bounce quarters off of, okay? And that's a standard hospital mattress. Unfortunately, that's still what they're using to measure pressure. Okay. So what you need to know is that everybody who comes in this facility is already on a pressure redistribution mattress. Okay? We've already taken that step. You need to be sure that that's in your documentation. Okay. So the risk factors that can be reduced by a support surface, you can reduce the pressure. Some of the mattresses are covered with Gore-Tex, which is a non-slip kind of material, and airflow can go through it. Seating and repositioning, you need to be especially careful of how much time someone sits in a chair or in the wheelchair, and time should be limited. If they're taught how to shift, and teach them how to shift, and it doesn't take long for you to go by and just help move somebody around if they're sitting in a wheelchair. You don't have to completely relieve the pressure, just juggle it. Many clinicians recommend a position change hourly, okay, for residents who are sitting or in bed or reclining in the chair with the head of the bed raised 30 degrees or more. And then wheelchairs are often used for transporting, but they severely limit repositioning and increase the risk of pressure ulcer, pressure injury development. Every paraplegic that you know that has a pressure injury, it's on their ischium from sitting in the wheelchair. Now you need to know, I'm not going to go into this, about picking out pressure reduction, pressure redistribution mattresses. There is a website with the WOCN Society, the Wound Osteoarthritis Nurses Society. You could go online and they have an algorithm that will help you pick out the proper mattress. Now let's talk about shearing. Shearing often looks like pressure injury, but it's not the same cause. Remember? You've got to pay attention to the cause. What shearing is you have someone in bed and they're sliding down, and when they slide down, their skeleton goes, gravity pulls the skeleton down, but their skin stays stuck to the bed. And so what happens is you kink off these vessels that go from the muscle and bone to the skin. You kink them off just like if I had a garden hose and there's water going through it and I bend the garden hose and the water stops going through. That's what happens when someone slides down in bed. You're kinking off the blood supply to the muscle and the bone. So the etiology of shear is the resident is sliding. They're either sliding down in a jerry chair, sliding down in the bed because they're trying to sit upright. Their head is raised over 30 degrees, or they're wheelchair sacral sitters. And a sacral sitter, and you know exactly what that is, instead of them sitting straight up, they're like this. Okay? So they're not sitting on their ischium, they're sliding down and sitting on their sacrum. So pressure shear damage. Pressure ulcers occur over bone, where the tissue is compressed. They're full thickness injuries that begin at the muscle bone layer. I keep telling you that. And the reason is because the muscle has the highest metabolic rate, and therefore this layer is the most risk. We used to think that pressure ulcers occurred at the surface, and then some bad nurse came along and didn't turn the resident, and then it turned, they called it a 1, and then they called it a 2, and then it was down to the bone. Now we know that it was down to the bone in the first place, and it took 2 or 3 days for you to see it on the surface. Okay. And when shear forces are involved, if you've got a resident who's sliding, what happens is they generally have undermining, and I'll show you pictures of that, where the opening looks to be like 2 or 3 inches, but if you get a swab down in there, it's 4 or 5 inches underneath of it. Or there's tunneling. So helpful hints are, if it's a pressure ulcer, and we're doing this because you've got to eliminate the cause, okay? A pressure injury is generally going to be round, Okay, because if you think about it, I have saran wrap on a pan and take my finger and push down on that saran wrap. You can almost see the concentric rings of energy. Okay, so pressure injury is going to be round. It's going to be 99.9.999 over a bony prominence. They're going to have that the bony prominence is going to be directly over a bed surface, a chair seat, or another bony prominence between their knees. Shear injury is triangular. It's more triangular than round. And if you think about it, if I'm sliding down in bed, isn't the injury going to be worse down at the bottom where it's kinked off more than it will be up to the top? So they're going to have undermining. It's going to be an area that contacts where the patient slides. They're usually a sacral sitter, or they're sitting up in bed, or they're in a jerry chair. Does that make sense to you? Now, pressure injury is lesions caused by unrelieved pressure that damages the underlying tissue. This is a pressure injury. That's a pressure injury. That certainly is a pressure injury. Can you see how deep they are? Now, there's incontinence-associated dermatitis. Okay. And what it is it's inflammation to the skin due to skin contact with an irritant, either stool or urine. See that? The implications are that you're going to have a harder time telling the difference between a, quote, stage 2 and an incontinence-associated dermatitis. I promise you it won't help you today, but in 5 years we will no longer have any stage 2 pressure injuries. Okay, we're getting there, but not yet. So the reason is IAD, incontinence-associated dermatitis, is a top-down injury. Okay. The stool irritates the skin, you get cracked and redness, and then releases cytokines, and then you have inflammation and then erosion of the skin. Okay. So, this is on the National Pressure Ulcer Advisory Panel website, this picture, okay? And I've suggested that you get a copy of this. Okay. A stage 2 pressure injury is going to be located over a bony prominence. They're going to have a patient, dependent on repositioning, it's going to have definite contours. You see that? I mean, you can see the edges to that wound. These, if it's not pressure, then if it's from trauma, if you have skin breakdown from trauma, like dragging the patient and friction, if they're restless and they're moving their heels up and down in bed and they have fragile skin, or if they have the presentation is that the contours match the fleshy areas exposed to the friction or the stool, okay? Those are not pressure injuries. Do not document any. I would suggest to you that any break in the skin that looks like a broken blister, okay, or could be a blister, you stop and think that it's probably something else besides pressure. So contrary to previous assumptions, pressure injuries occur from the bottom up, not the top down. So your assessment parameters, okay, now this is where your aides can go if they want to. If you want to leave, you can go.
Everybody have their, wait a minute before y'all start running out here, because we got a post test we gotta do, but I need everybody's fit test real quick.
Now you're welcome to stay if they want to, can't they? This is helpful.
here when you did it last time.
Oh, were you here last time? Same thing?
Circle, make sure you
So
circle
in
toes
stage
together.
2, you say it's going to be gone.
They'll be gone.
Is it going to be, how is that going to be fixed in the system during the staging?
Well,
What's going to replace it, or how is it?
there won't be a replacement because it won't exist. Okay, because we're going to find out that it's not a top to bottom. It's always, pressure injury is always going to be with the muscle or fat layer, okay? Now the problem is you've got people who are so invested in staging that they're fighting that tooth and toenail, and it's going to
So
happen.
instead of staging, it's just kind of like, call it what it is, instead
It-
of like,
it-
let's go off the staging.
For the pressure ulcer, the guideline that I showed you, the first edition, we didn't even mention staging. Because I hate it. I hate staging. I have fought it for 30 years. I fought it because it serves no purpose. And I'll go into why it doesn't. And we spend so much time on it when it doesn't make any difference. If it's a full thickness wound, it's a full thickness wound. You know. Okay, can you hear me if I go on? Probably not. Okay, so I'm going to say you stage pressure injury only. Okay, if I don't say that again, it's not the most important parameter. This is what I've been lecturing you about, okay? It's not the most, the staging has absolutely, staging doesn't direct treatment, it doesn't tell you what to do with the wound, okay? And it doesn't reflect the progress in healing. You can't go from a 4 to a 3, okay? Or a 3 to a 2. And while I've got you, I'll tell you why that is. Because once muscle is gone, it's gone forever. It's replaced by granulation tissue. Okay. So at stage 3, once the fat tissue is gone, it's gone forever. It's replaced with granulation tissue. That's why sometimes when you see a scar, you can tell how deep the wound is or was to begin with, because if you try to move it and it doesn't move, then that means it was down into the muscle. Am I making sense? It also requires an excellent understanding of anatomy. I really have worked on the national level, and I did the wound association and so forth. And I've had wound nurses with the same experience that I have, and we don't always agree on what staging something is, okay? Because now, to me, you can look at a partial thickness wound and it looks like dermis, okay? But you're down into muscle tissue. And the problem with stage 3s, problem with stage 3s is you're down into the adipose, into the fat, okay? Fat has no blood supply of its own, so it necroses immediately. Can you stage a wound with necrosis? No. Okay, so anyway. It requires anatomy, and it's based on the National Pressure Ulcer Advisory Panel system, which I think the wound osteoincontinence nurses should have separated from that years ago, but so be it. Okay, now they're saying that you can't have pressure injury to mucosal membranes. Hello. Okay, stage 1, pressure injury stages. This is a white person. Layer 1's epidermis, the second layer is the dermis, the third layer is the hypodermis, or fat layer, the fourth layer is muscle and bone. A non-Caucasian person, it's exactly the same thing. It's just that the epidermis has melanin in it. Blanchable and non-blanchable, I just simply mean, this is what they talked about stage ones, that if you pressed it and it remained red, then so be it. That's going to go away too. Okay, so there's stage 1, stage 2, down into the dermis. Stage 3, now we're down into the hypodermis. This is a pressure injury with a pibulate. Okay, the pibulate is okay. Here's in an ideal world when you've got a wound healed, the granulation tissue comes up, the epidermis comes up, and they all meet at the same time. Okay. What sometimes when the granulation tissue comes up first, or comes up higher, then you've got what's called hypergranulation, where the granulation tissue is higher than the skin around it. Those aren't going to heal because epidermis can't grow uphill. Okay. So you've either got some silver nitrate or get someone to cut it off for you. Okay. But this is a pibulate, and what happened with a pibulate is that the epidermis got there first and couldn't float across the granulation tissue, so it curled under. Okay, and forms a roof. Whoops, sorry. And forms a roof. See that? Once you've got that roof formed, then your wound isn't going to heal either. It's just like if you tape my 2 fingers together, you could keep them taped together for years and I'd still have 2 fingers. Or you could just scrape the skin off of one and tape the other one to it. This epidermis is intact, this one's going to heal. But if you scrape both of them off and put them together, then I would have 1 finger. Okay. So what I'm telling you is once that epibole forms, once you get that roofing, the granulation tissue is going to come up, but it's not going to be able to seal across the wound. Okay. Now one of the things you can do about that is as your wound is healing, take a swab and make sure that you kind of rub that skin that's starting to turn under. Or if you've got someone who uses silver nitrate. I used to get a curette and just slide it around. Okay, a deep tissue pressure injury. Okay, that's where the injury has occurred at the base and it hasn't decayed and showed on the surface yet. This is unstageable with dark black eschar. This is unstageable with slough and eschar. Eschar and slough are the same thing, except one's dry and one's wet. They're both dead tissue. This is a stage 4, down to muscle and bone. Okay, this is a stage 1. This was a little lady that I was taking care of, and someone put a barrette in her hair, and she leaned back on her wheelchair and caused that redness. Okay, staging a deep tissue injury. That's a deep tissue injury. Okay, that's on a heel. Purple, maroon is your clue. Anytime that you see something that looks bruised, make sure that you say it could be a deep tissue injury. Okay, cover your bases. If it's not, it doesn't make any difference. Okay, but if it is, and then it deteriorates, and you've got a full thickness wound, then you'll wish that you had said it was. Okay, so any blood-filled blister should be called a deep tissue injury. Sometimes they're really hard to see on dark skin, and the evolutionary response to treatment, you just never know. Okay, see that? That happened on an OR table. Okay, stage 2s. Okay, this happens to be mine. That is a serum-filled blister. Now these are partial thickness wounds involving the epidermis and possibly the dermis. By the way, when we were getting the guidelines together, we had a terrible time finding stage 2. What all of us would agree could possibly be a stage 2. Okay, these are not pressure injuries. These are all incontinence associated. This one gets called pressure a whole lot of the time, but you can't break down in the gluteal cleft. There's no bone there. See that?
said I don't even care.
Okay, the challenges are if you have epidermis, the dermis is exposed. By the way, this is not, whoops. This is one of my pictures. This is not a pressure injury, it's a burn. But I wanted to show you how the bright red capillary beds show. If you can find a wound like that.
So
There's,
on the other side, I'm sorry, the gluteal cliff you're
yes,
looking at, you said was not a pressure injury.
right.
What would you classify that as? That second picture?
It has to be from incontinence. Okay, I mean there can't where the stool or
I
the
see a
urine.
lot of those.
Yeah. Well, that's what it is. Okay, it's something or sweat sometimes, or here's what I found. Was always had a hard time on my surgery floor in the hospital because those aides, by golly, you got to have everybody clean. But one of the things they would do is they would turn the resident to the side to clean them, and they'd pull the buttocks apart and actually split that skin. Okay? So I think it's, that could be, that skin got really irritated, maybe from, getting clean, and people with ample bottoms, it's hard to get all of that perspiration and yeast out of there. And so the skin becomes really fragile, and then I think just pulling, trying to clean, you can split that skin very easily. But I'd call it trauma. If you're not sure it's incontinence, then trauma.
I mean, it's the IAD and.
Yes. I mean, that's what I'd call it. I'd call it incontinence-associated dermatitis. That's exactly what it is. Okay.
So
And,
like one on the bottom right there,
yeah,
I could see coming into a nursing home, doing your assessment, and they say, we're going to say that's stage 1. Because, real world.
sure,
Yeah.
in real world,
we
but that's
want
why
to
I'm
say
here.
They came in.
Yeah, but that's why I'm here, okay? Because if you look, all this skin is compromised. It's not just in one place where pressure could cause it, okay? You've got compromised skin from incontinence, and that's probably friction. And I'll tell you something else, and I think we need to watch really carefully with our aides, when they're cleaning, and you'll know who they are. The ones who just clean, and they'll scrub off that barrier down, down to the dermis to get them clean. So what you need, one of the things I always said was I wish that I could just buy skin concrete and put it on bottoms, and then all they could do is just clean the stool off the top of the concrete. So just think and teach them that way. Pretend this is concrete, and think about it. The barrier is there to keep the stool from getting on the skin. Okay. So all you need to do is get the stool off the barrier. But we nurses sometimes have a real problem with that. We want to make sure they're clean. But I'm sure that that's what happened. And so what you do is you look at the surrounding skin. Because if it's pressure, it's just going to be in one area. And so the way I chart that is I'm breaking the integrity of the skin associated with incontinence, associated dermatitis, with surrounding compromised skin. Okay, I've talked enough about that. So stage 3s are full thickness. By the way, this is my picture too, and it was the only one out of 50 WOCN nurses to come up with a stage 3 that they would bet that it was. So, and this is hypodermis, and it's clearly fat. Okay. And the depth depends on where it's located. Okay. So you could on your nose, you could be down, get a stage 3 from an oxygen mask. But on my bottom, I'd have a stage 3 that could be that deep. Okay, so you can't go by depth. You have to look at the tissue and guess what it is. What I'm doing. Okay, stage 4s are easy. You're down into muscle and bone and tendon. And I don't know what, remember I said, you need to remember that if you see any dead tissue, it can't be a tube. Okay, because dermis doesn't sustain necrotic tissue. Okay, these are unstageable because you cannot see the base of the wound. You can only stage if you can actually look at the base of the wound and tell me, what am I looking at? Okay. They're unstageable. The full thickness lost, but the wound bed is secured by necrosis. Staging is delayed until you can see underneath of that. If the wound is partially necrotic, but you can see muscle and tendon, then go ahead and stage it. It's a 4, it can't get any deeper than that, okay? And you can stage only, you can't stage if you only see subcutaneous, and to stage the wound if the base is totally obscured. Okay. Any pain, just because we care about our patients, we need to pay attention to pain. And one of the things that's really distressing me at this point in time is all the stuff about opioids, okay? And I think when you're 85 years old and in a nursing home and you say you're hurt, fix it. Okay, just fix it. I once had a patient who was, I think, 87, and I put him on hydrocodone, and I'm a nurse practitioner. Put him on hydrocodone, and his daughter came in and was just absolutely livid with it, because he could get addicted. And I said, I'll tell you what, let's take care of his pain now, and when he's 90, we'll send him to drug rehab. Whatever. So you just need to pay attention to it, whether it's episodic or, if it's occurring just when you do your dressing change, then for heaven's sakes, call the doctor and get something. If it's all the time, then for heaven's sakes, call the doctor and get something to relieve that pain. So how do you determine the process, the progress? Pay attention to what somebody charted before you, okay? And don't chart just what somebody else charted. You need to, the way you can see if the wound's healing is there less dead stuff, is there less swelling, is there less redness, is there more granulation, is there more epithelial? If there's no progress in 2 weeks, you need to pay attention, and there should be less drainage and less pain. Okay. Healing in 2 weeks, partial thickness wound, stage 1s and 2s, should be epithelialized within 2 weeks. Never any, 3 weeks at the most. And that's skincare stairs too. Full thickness wounds, 3s and 4s, should show a decrease in size. If there's no sign of healing in 2 weeks, you've got to get hold of the doctor and say, this isn't working. Request a change of treatment. Change the treatment. Okay. Doctors don't know anything about wounds. So you should do a comprehensive assessment and documentation on a weekly basis. And then at every dressing change, if there is a change, any change in the status of the wound bed, if any change in the volume and type of drainage, any change in the surrounding tissue or skin. Documentation should be, what is this wound? What caused it? If it's a pressure ulcer, you need to describe it. What is the progress that it's making? If infection is present, the presence of pain, what did you do to address the pain? What did you do to address the infection? A description of the dressing and treatments. Okay, you notify the doctor of a change of condition that could increase risk. You've got someone who's not eating. Okay, you need to pay attention to that. One of the worst pressure ulcers I've seen was a little walkie-talkie we had in the nursing home, and she got a urinary tract infection and went to bed and stayed there. And nobody noticed that she wasn't up and walking around and reported it or whatever. And she had fever and wasn't moving and wasn't eating. Okay. Any increase in wound size, increase in drainage, increase in odor, increase in pain, erythema, redness that's greater than 3 centimeters, and no signs of healing in 2 weeks. Okay, do you have questions? Okay, take the post-test. Thank you for your time and attention.